Is about febrile seizure. Febrile seizure is something that is very distressing for the parents as well as a very common encounter in the emergency setting. You need to know about certain definitions, certain risk factors of the recurrence of such episodes, certain risk factors for developing subsequent epilepsy after these febrile seizures, and also how to manage and counsel the parents is a task when you are dealing with a child with febrile seizure. Now, first of all, coming on to the definition, how do you define a febrile seizure? We define febrile seizure as a seizure that happens between the ages 6 and 16 months. Peak of the occurrence is 12 to 18 months with a temperature of 38 degrees Celsius, that is 100.4 degree Fahrenheit or higher, and this should not be a result of CNS infection, any metabolic imbalance, and lastly, there should not be a history of previous afebrile seizure. So, in a nutshell, any febrile seizure is a seizure that happens that is associated with a fever of high temperature, 38 degrees Celsius, that is 100.4 degree Fahrenheit or higher, and the age group defined is 6 and 16 months. Also, this should not be as a result of CNS infection, any metabolic imbalance, and there should not be any history of previous afebrile seizure. Now, there are certain terminologies that you should be well versed with. These are frequently asked in the exam and also sometimes confusing. These are simple febrile seizure, complex febrile seizure, febrile status epilepticus, and FIRES, that is febrile infection related or refractory epilepsy. Now, coming to the simple febrile seizure, there are certain characteristics of the seizure that happen, and if such characteristics are there, these are suggestive of a simple febrile seizure. When we talk about a simple febrile seizure, such febrile seizures are mainly generalized seizures, usually tonic-cloning, and this attack is associated with a fever. Usually, these seizures are short duration. Of short duration, they last for a maximum of 15 minutes, and they happens only in a single episode in our day. They are usually not recurrent within 24 hours. So, simple febrile seizures, whenever you see a particular characteristic of being generalized, tonic-clonic, short duration seizures, maximum of 15 minutes, also not recurrent within a 24-hour period, you label as simple febrile seizure. When we talk about complex febrile seizure, they are more prolonged, of a duration more than 15 minutes, and they can be focal and recur within 24 hours. If any of these is present, then you label that febrile seizure as complex febrile seizure. If such a febrile seizure happens for more than 30 minutes, then we label it as febrile status epilepticus. Now, the last terminology that we are going to discuss is FIRES, that is febrile infection related or refractory epilepsy. Remember, this is a completely different disorder that happens in older children more than 5 years of age, predominantly in male population. What happens in FIRES? Initially, there is an encephalitis-like illness, and we cannot find any we cannot identify any infectious cause of that encephalitis-like illness, and later on, they develop a difficult to treat epilepsy. Before happening of such seizure, they are previously normal. So the initial episode is somehow confused with an atypical febrile seizure, but later on they develop a difficult to treat epilepsy and may have a poor developmental outcome. Now, coming to the epidemiology of the febrile seizures, it is seen that around 2 to 5% of the neurologically healthy infants and children, they experience at least one febrile seizure in their childhood. And usually such seizures are simple febrile seizures, and simple febrile seizures, they do not have per se any effect on the overall mortality or poor developmental outcome in the near future. But when we talk about complex febrile seizure, it is seen that there is twofold increase in the long-term mortality rates over the subsequent years. When you compare it to the general population, those who have experienced complex febrile seizure, there is actually a twofold higher risk of mortality. Now, coming to the risk of recurrence. whenever a febrile seizure happens, obviously the parents would be in distress and they would want to know that what is the chance that my child might experience such attack further in the future, right? So there are certain risk factors that predict the recurrence of such febrile seizures. We will discuss about each of these factors in details in the next slide. But overall, you should know that if there is a single episode or one episode, the risk is somewhat near 30%. There is a 30% chance that these will recur. If there are two or more episodes, then the chance is 50%. And in smaller children less than 1 year of age, the chances of recurrence is 50%. When we look at the cohort of the children who have experienced who have epilepsy, it is seen that 15% of the children with epilepsy have febrile seizures. But when we look at the cohort of children have experiencing febrile seizure, it is seen that only 5% will experience epilepsy in the near future. So, depending on the risk factors, we will discuss further. So, the association is clear here. If we take children with epilepsy, 15% will have febrile seizure, has experienced febrile seizure somewhere. But the children with febrile seizures, only 5% of those, and the risk ranges from 1 to 33%, they will have epilepsy in the near future. Now, coming to the risk factors for the recurrence of the febrile seizures. The major risk factors include age. Smaller the child, more are the chances of recurrence. Duration of the fever. If seizure happen in a short duration of the fever, if the fever was just for a duration of less than 24 hours and still the febrile seizure has happened, there are higher chances that fever will recur again. The seizure will recur again. So duration of the fever at less than 24 hours is another major risk factor. The third major risk factor is the spike of the fever. Fever between 38 to 39 degrees centigrade, that is 100.4 to 102.2 degree Fahrenheit, is considered to be a major risk factor. So, the major three risk factors for the recurrence of a febrile seizure include age, less than 1 year, duration of the fever, less than 24 hours, and the spike of the fever, 38 to 39 degrees centigrade, is considered as a major risk factor for the recurrence of the episode of febrile seizure. Now, coming to the minor risk factors. The minor risk factors include a family history of febrile seizure, family history of epilepsy, a complex febrile seizure is likely to recur, a child in a daycare setting, male gender, and lastly, if the serum sodium levels were low at the time of presentation of the febrile seizure, it is also considered as a minor risk factor for recurrence of the febrile seizures. We quantify the risk on the presence of these risk factors. It is seen that if none of these risk factor is there, then the rate of recurrence, the risk of recurrence is very low. It's around 12%. If any one risk factor is there, then it's around 25 to 50%. If there are two such risk factors, then risk increases to 50 to 59%. And three or more such risk factors, there is 73 to 100% risk of developing a recurrent febrile seizure. So, whenever you encounter a child with febrile seizure, you look at the risk factors and you quantify the risk of recurrence of such febrile seizure and counsel the parents accordingly on how to manage the child if such a seizure recurs. Right? Now, coming to the risk factors of developing subsequent epilepsy. These children with the febrile seizure, they have a risk of developing subsequent epilepsy, and such risk factors are described here. If the child experienced a simple febrile seizure, there is just 1% chance risk of developing subsequent epilepsy. If there are recurrent febrile seizures, the risk increases to 4%. If there is a complex febrile seizure, In complex febrile seizure also, if the duration was more than 15 minutes or there was a recurrence, then the risk for subsequent epilepsy increases to 6%. If the fever was just 1 hour, the duration of the fever was less than 1 hour before the febrile seizure, then the risk of subsequent epilepsy is 11%. Any family history of epilepsy, the risk is 18%. A complex febrile seizure that was focal, 29%. And lastly, if the child had any previous neurodevelopment abnormalities, then the risk of subsequent epilepsy is 1 to it is 33%. So the risk of subsequent epilepsy ranges between 1 to 33% depending on the risk factor. It is seen that the risk is lowest with the simple febrile seizure and highest if there is any neurodevelopment abnormalities. Remember, in complex febrile seizure also, we needed any one of the three, right? Either a prolonged duration more than 15 minutes, either recurrence within 24 hours, or a focal component. If the seizure is prolonged more than 15 minutes and recurrence is there, then the risk factor is just 6%. But when we talk about focal complex febrile seizure, the risk is 29%, right? You compare 6 and 29, right? There is a vast difference. So, you should know these risk factors and the risk of subsequent epilepsy. Remember, if more than one of these factors is there, then their risk will add on. Like if the child had a family history of epilepsy and a single febrile seizure. So now the overall risk would be around 18 plus 1, that is 19%. Right? So these the risk, these are additives if one or more of these risk factors are present. Now coming to the genetic factors, what all genetic background is there when we talk about febrile seizures, and what is the etiology or the etiopathogenesis when we talk about febrile seizure. So it is seen that there is a family history is positive in many patients of febrile seizure that we encounter, and in such families it is inherited as an autosomal dominant trait. There are multiple genes that are involved. Most of these are involved in various epilepsy syndromes as well. The sodium channel genes SCN1A, 1B, 9A, and CPA6. We know that a family history of febrile seizure is also considered as a minor risk factor for recurrence of such febrile seizure. So, coming to the basic etiology, what is the hypothesis? What is the possible etiology? It is hypothesized that there is an imbalance between the inflammatory and the anti inflammatory factors, leading to an heightened inflammatory state that is prone to throw seizures. So, there is a dysregulation between the pro inflammatory cytokines and anti inflammatory cytokines. Pro inflammatory interleukin 1B, interleukin 6, interleukin 8, and anti-inflammatory ILR1A cytokine, right? So it is thought that there is a dysregulation between this pro-inflammatory and anti-inflammatory cytokines, and that's why a decreased anti-inflammatory to pro-inflammatory ratio, that is a decreased ILR1A to ILH ratio, is thought to be a potential biomarker to detect all those patients that have developed that have a risk of developing a mesial temporal epilepsy in the later life, right? A few epilepsy syndromes are also associated with febrile seizures. They initially present as febrile seizures, and later on you identify the peculiar semiology, EEG features that tell that this is an epilepsy syndrome. There will be a thorough video on epilepsy syndromes where we discuss different types of epilepsy syndromes, the semiology, and also a video on the basics of EEG, where we will be solving some questions, commonly asked questions related to the EEG picture and these epilepsy syndromes. So certain epilepsy syndromes that are related with febrile seizure need a mention here. Three of such syndromes are Jeff's plus, that is generalized epilepsy with febrile seizures plus. The second syndrome is severe myoclonic epilepsy of infancy, that is also sometimes referred to as SMEI or Dravet syndrome. The third is temporal lobe epilepsy, that is secondary to the mesial temporal sclerosis. A brief mention about all of these. We'll be talking about these in detail as well, but this is a general recap or basic intro about these. So Jeff's plus, that is generalized epilepsy with febrile seizure plus. It is an autosomal dominant syndrome with a very variable phenotype. The onset of such syndrome is usually in the early childhood and they show remission usually in the mid childhood. What happens in such a syndrome? There is multiple febrile seizures and subsequently there would be afebrile generalized seizures including generalized tonic-clonic, absence, myoclonic, atonic, astatic seizures, and these have a variable intensity, right? So, Jeff's common history would be initially in the childhood period, the child had multiple febrile seizures, but after that, the child starts throwing afebrile seizures as well. And the morphology, the semiology of seizures is different, right? There are multiple types of seizures that are shown. The second is Dravet syndrome. This is the second epilepsy syndrome that is associated with febrile seizures. It is actually the most severe of the phenotypic spectrum of the febrile seizure associated epilepsies. It is a distant entity with an onset in infancy. What happens here? There are febrile and afebrile unilateral clonic seizures that happens every 1 to 2 months. Typically, they are induced by fever, but they differ from the usual febrile seizures in that because they are more severe, they are more prolonged, they are more frequent, and they are focal and they happen in clusters. They usually start to occur with lower fevers and later on they happen without fever as well. During the second year of life, myoclonus, absences, and focal seizure also happens. And because of such a high seizure load, developmental delay usually follows. So whenever we talk about Dravet syndrome, it is a very severe variety, the severe end of the spectrum of the febrile seizure associated epilepsy. The onset is in infancy only. Usually, there would be afebrile as well as febrile seizures happening at a lower temperature, and also there would be prolonged, there will be much more recurrences, and later on, because of the high load of such seizures, there would be developmental delay in the future. When we look at the genetics of Dravet syndrome, usually they are caused by a de novo mutation, but rarely, in some familial cases, it may be inherited in an autosomal dominant manner and sometimes may be affected from a non affected carrier infant. The mutation here is in the SCN1A gene, and these are the most common cause of Dravet syndrome in about 80% of the cases. It is seen that the same gene is mutated in the GIF spectrum as well, but these mutations are more severe. They are thought to cause a more severe phenotype because these are loss of function mutation. The milder variant also happens with the Dravet syndrome, but they manifest in some and not all the above feature would be there, and they are referred to as SMEI borderland. Some other mutations that are identified in Dravet syndrome are GABRG2, SCN1B, SCN2A. Remember, in 10 to 20% of the cases, no such gene specific gene mutation is identified. So, whenever you think about the genetics of the Dravet syndrome, it is similar to that of the Jeff's, but it lies on the severe spectrum, right? So, there are loss of function mutations that lie on the severe spectrum. The milder variants are thus referred to as borderland. Now, there is a pre-notion. There was a pre-notion of vaccine encephalopathy. There is a concept of vaccine encephalopathy that in infancy period, the child receives a vaccination. Following that, he develops fever and starts throwing seizures, right? And these seizures are actually of a severe phenotype, right? These seizures are not like simple febrile seizures. They are severe in the variety, and they were referred to. This was referred to as vaccine encephalopathy. But it is seen that these children actually had some predisposition earlier also. They had some genetic predisposition, and they turn out to be Dravet syndrome because the mutations were very similar to that of the Dravet syndrome. So now there is a controversy that whether a term like vaccine encephalopathy persists or not is actually a valid term or not, or these are just Dravet syndrome babies having a genetic predisposition and fever was just a ignition point that started this disease. So this there are doubts about the very existence of the vaccine encephalopathy. Coming to the evaluation of a child with febrile seizure, as soon as an age group of 6 to 16 months, previously neurologically normal, presents to you with a seizure episode, you rule out CNS infection and metabolic abnormalities, and previously any history of afebrile seizures. You go for the history examination, you manage the febrile seizure, the acute management, and the acute illness. And next step would be to determine the risk factors for the recurrences and estimate the risk. Whenever you are managing with a child with a febrile seizure, it is very important to stabilize the child initially, elevate the anxiety of the parents or the caregivers, and whenever as soon as the child is stabilized, you counsel the parents regarding the risk and the gravity of the situation. You look at the risk factors of the recurrence of febrile seizures and estimate the risk accordingly. If the risk of developing a recurrent seizure is high, you obviously counsel the parents about the risk of recurrence and how to manage such a child at home, right? Parents or the caregivers need to know the management at the house or wherever the child may be, in the daycare setting or wherever the child is there. If there is a recurrence, how to manage the child accordingly. And lastly, you determine the risk of epilepsy. There were certain risk factors. If the risk of epilepsy is very high, which is in a very rare case, then you investigate, you go to do EEG, imaging, intermittent oral diazepam prophylaxis is given. So if I need to make a flowchart of the evaluation, initially you do history examination, you manage the acute illness, manage the acute seizure, and you determine the risk factors. And according to the risk factors, you counsel the parents and educate them regarding the management. Once this is done, you look for the risk factors for epilepsy. If the risk factor for developing epilepsy is low, no further investigations are to be done. But in rare cases where the risk factor for epilepsy is high, you have to go for EEG, imaging, right? And also you have to start an oral intermittent clonazepam. Now, coming to the role of lumbar puncture in such cases. In the definition, we have discussed that that seizure should not be a result of CNS infection. So, how do we rule out the CNS infection? Do we need LP in all the cases? So, in children that are younger than 6 months, you have to do LP. In children that are looking sick, you have to do LP. If there are certain clinical signs and symptoms that are very concerning, that makes you suspect meningoencephalitis, meningitis, then you do the LP. If the child is around 6 to 12 months of the age and the vaccination status is not very clear, you know that the child is not being immunized by hip or pneumococcal vaccine, or the status is generally unknown, you go for LP. So overall, we don't need an LP whenever you encounter a child with febrile seizure. But in 4 situations, you will do LP. What are these 4 situations? First of all, broadly, less than 1 year, you have to do LP, right? Less than 6 months, anyways, you have to do 6 to 12 months. If the immunization status is hazy, you don't know the immunization status, hip and pneumococcal are given or not, you have to do LP. If the child is generally appearing very sick, then you have to do LP. And lastly, if there are specific signs and symptoms that are very concerning, you feel that the child is having meningitis or meningoencephalitis and there is some infective cause, then you have to do LP for diagnostic purposes. Now, coming to the role of EEG. EEG, we know that in the hierarchy of the evaluation, EEG came when there was a higher risk of epilepsy. Then we were doing EEG to trace the pattern of an epilepsy syndrome, right? So, EEG is not routinely done. EEG is done just to because EEG would not predict the future of the recurrence of febrile epilepsy, right? And also, if the EEG is performed within 2 weeks of the febrile seizure, it might show some non-specific slowing, usually in the posterior. Thus, if alone an EEG is indicated in higher in children that have a higher risk of epilepsy, then it is delayed or repeated after more than 2 weeks. And EEG thus should be restricted to only special situations, not always done, because it will neither help us to predict the future recurrence of the febrile seizures or risk of epilepsy. Right? There were some clinical factors only that we were using to calculate the risk of epilepsy and recurrence. EEG was not there anywhere in the evaluation except in last situation where the risk of epilepsy was very high and we want to pick up some epilepsy syndrome, right? Remember that if an EEG is done within 2 weeks of the febrile seizure, it will show you a non-specific slowing, and this should not be considered as abnormal EEG. It is thus preferred that you do an EEG if and all it's warranted after 2 weeks. Now, coming to the blood studies. As soon as you receive a child, basic investigations you do, right? You take the blood glucose and look for any hypoglycemia. And also, if there is a history that the child had poor oral intake, in all those situations, you do a blood glucose. This is an emergency investigation. You prick and take and measure the blood glucose by the glucometer. But the other blood studies like electrolytes, calcium, phosphorus, magnesium, CBC that you do in other scenarios where you encounter a child with acute seizure, they're not routinely recommended in the workup of a child with the first episode of the simple febrile seizure, right? And also serum sodium levels, we read in the risk factors of the recurrence of febrile seizure. Serum sodium level, a low serum sodium level is associated with a higher risk of recurrence of a febrile seizure within 24 hours. So you can perform a serum sodium level if and all you are withdrawing some sample. Now, coming to the imaging, normally CT or MRI, they are not recommended in evaluating a child after the first simple febrile seizure. They are done only in the workup of a child of suspected epilepsy. Coming to the treatment, the initial treatment would be focused towards aborting the seizure, right? So you can give a rectal diazepam, or the more preferred one is intranasal midazolam. Rectal diazepam in the dosages of 0.2 to zero point 0.5 mg per kg is often prescribed, and this has to be given at the time of recurrence of such febrile seizure after when it lasts longer than 5 minutes. It is important to note here the duration of 5 minutes. Certain books give a range of 3 to 5 minutes, but you have to remember the term 5 minutes, which is given in Nelson as well as in the AOCN guidelines. So, any seizure, if it lasts for more than 5 minutes, you have to give rectal diazepam 0.2 to zero point 0.5 mg per kg. Or sometimes this rectal diazepam is uncomfortable for the child as well as very uncomfortable for the parent or the caregiver to administer any drug rectally. So intranasal midazolam sprays are now available very easily and they can be used. You can give buccal or intranasal midazolam in the dosages of 0.15 mg per kg, and it is a preferred mode of treatment by most of the parents. Now, if I encounter a child with febrile seizure, for how long should I observe the child? Ideally, they should be observed until they are awake and alert. That means once the post-ictal phase is over, you can just discharge the child, counsel the parents about the risk of the recurrence and how to manage at home. Also, if any risk of epilepsy is there, you counsel accordingly, right? But they are, if everything is fine, you just observe till they are awake and alert, and you can discharge. And children that are, especially those with the first febrile seizures, when all they should be admitted, there is a list that if any of these are present, then that warrants admission. If the child is lethargic beyond that post-ictal state, then obviously you need to keep the child admitted. If the child is unstable, then you have to admit. A child less than 18 months of age, higher chances of meningitis, higher chances of recurrence, you need to admit. Any complex feature is there, you need to admit for workup evaluation as well as because these are more likely to recur. If there is an uncertain home situation, we don't know whether the child would be always in the surveillance of a educated caregiver who can manage, then also you need to admit. If there is an unclear follow up, then you also need to admit. And any child with the slightest suspicion of meningitis should also be admitted and investigated accordingly. So, these are all the situations where you need to admit, otherwise, you need to just observe the child till the child is awake and alert, and then you can plan the discharge. Now, there are certain therapies after the acute management of the seizure and counseling for the recurrence of the seizures. There is some intermittent therapies and continuous prophylactic therapies. Coming to the intermittent prophylaxis therapy, these are actually not indicated in the first episodes. These are given if there is any recurrent or prolonged seizure. How do I define recurrent or prolonged seizure? This is a clinical. This is something that is decide on the clinician. That depends on the clinician. If I feel that there is 2 or 3 episodes that might be recurrent for me, might not be recurrent for some other clinician. So whenever there is recurrence, very recurrent seizures, prolonged seizures, you give this intermittent prophylaxis. Also, in complex febrile seizure, intermittent prophylaxis is given. We give oral clobazam, that is labeled as sold as tablet frisium. Oral clobazam in the dosages of 0.5 to 1 mg per kg per day. This has to be given in two divided doses over 3 days, right? 3 days starting from the day or day one of the fever. Day one of the fever, you continue for the 3 days and then stop. So this is whenever till the age of 5 years fever happens, you advise to give a prophylactic clobazam tablet for 3 days beginning from the day of the seizure. Comes the continuous prophylaxis. Continuous prophylaxis you give whenever you encounter a child with frequent complex febrile seizures, febrile status epilepticus, any febrile seizure with neurodevelopmental delay, and Jeff's plus with an afebrile seizure. So all these high risk situations where there are chances of developing subsequent epilepsies and recurrence of seizures, then you have to start an anti-epileptic therapy. The drug of the choice here is valproate. It is given as a continuous prophylaxis. It has to be continuously given, and you can stop it only after 2 years of a seizure free period. Coming to the antipyretic therapy. Antipyretic therapy is obviously given for that acute febrile illness. It alleviates the discomfort of the child, makes the child more comfortable, right? But remember, most of these children need to be given antipyretic therapy very cautiously, because it is seen that using round the clock prophylactic administration, it doesn't have any effect on the incidence and the recurrence of febrile seizure, and thus it is not recommended. It is also not recommended to treat children with febrile seizure using a daily anti-epileptic medication, because there is high likelihood of adverse effects. So using antipyretic therapy only when it's needed. It will just help in comforting the child, not in the overall incidence of the recurrence. Round the clock administration is not recommended. And also, continuous prophylaxis with anti-epileptic drugs, giving anti-epileptic drugs is also not recommended because of the side effects they have. So this completes the discussion of febrile seizures. All you need to remember here is the risk factors that are associated with the recurrence of febrile seizures, the risk factors for developing subsequent epilepsy, the acute management, intermittent prophylaxis, continuous prophylaxis, and also the definition of the terms simple febrile seizures, complex febrile seizures, JEFs, fires, certain epilepsy